Good morning, everyone, and welcome to the Iowa Poultry Association webinar series. We will wait just one more minute to give a few of the late people dialing in a chance to log on, but we'll get started very shortly.
So there's a reproductive tract with all being all cis.
So just to give you a heads up, as we do get started, there is a chat option on your screen where you can alert us to any concerns or problems that you might be having with the audio or the visual for that matter. And you can see where Tom and the Center Fresh group have already started the chat there. So we appreciate Tom for calling that out for us and alerting that to everybody else so they know they have that option. We will be holding at least the majority of the questions until the end of the presentation. So this might be one option for you to log in some questions if you'd like to, so to make sure we don't miss that at the end of the discussion. Well, I see it's 11:02, so we'll go ahead and get started to be respectful of everybody's time. Again, we appreciate you logging in and joining us for the Iowa Poultry Association webinar series. Today's topic is infectious bronchitis and non-layer syndrome. I appreciate the presenters joining us today, Dr. Bernie Beckman from Highline, Dr. Yuko Sato and Dr. Mohammed El-Ghazar from Iowa State. Appreciate Dr. Beckman for alerting us to this topic several months ago. We've had this on our webinar schedule since around the first of the year, and know that this is a topic that is getting discussed in the industry quite a bit. I'm going to just kick it off. This is Kevin Stiles from Iowa Poultry Association. We have certainly welcomed your feedback on both today's webinar as well as if you have any topics or comments on the webinar series in general. We're always receptive and welcome those comments. And then also would like to alert you to know that this webinar is being recorded, and so you can find it both on our website but also on our YouTube channel. So we'll be sending that link out at a later date, or probably later yet this afternoon, so that you have that available to you. But again, thanks everyone and welcome today. I'm going to invite Yuko to come up and kick things off. Yuko.
Thanks, Kevin. Well, good morning. I'm sorry it's 2 times in a row that you have to hear my voice. I don't like hearing my voice either, but I'll set the stage first before Dr. El-Ghazar and Dr. Beckman talk about the non-layer syndrome. Okay, so going over briefly, what are the other causes of egg drops? Kind of very broadly. So I'm going to categorize them by viral, bacterial, and sort of miscellaneous. So out of the other viruses available, there's 2 that also affects the internal and external egg quality. That's AI and Newcastle, things you don't really want to see ever. And then you have more common things like ILT that can also cause production issues kind of indirectly. Hopefully things you also never see are AE and ART and also egg drop syndrome. So those are kind of generic other things that might cause egg drops. Here are some of the other bacterial, some of the more common ones like MG. Most of the flocks that may have had exposure to MG are typically vaccinated with an F strain that can prevent some of these production drops. Some of the other common ones include FDN. Again, we are starting to creep up again on seeing the issues again. I know after AI, we saw a drop in these cases, but you can certainly see low case weights and also production drops with FDN. And actually, Bernie's more well-versed in FDN than I would ever be. And then another kind of questionable one is Brachyspira. There's been some reports out in Europe where they're seeing a lot of drops in egg production as well, too. So here are some other ones. And again, obvious ones that are related to egg drops, like nutritional and management type diseases, things you can't control, like act of God, like stress with weathers and temperature, lighting issues, and then some of the things that you don't think about are availability of water. I had some farms that had some stray wires, and the birds were scared to go to the water lines, and that's how they had some pretty significant egg drops because they can't drink any water. Okay, so I'll kind of go through a brief introduction of infectious bronchitis. It is a coronavirus, and I'll go through that in a little bit. Usually the infection is respiratory at the beginning. This virus is aerosol, and it could be transmitted up to 1,200 yards by air. By infection, you can get the virus positive in the bloodstream 1 to 2 days post-infection. So it's pretty fast, but the spread is relatively slow. But the oviduct infection can be relatively fast. So imagine if you are a naive chick that's even pretty young in age, you can get that infection and get a respiratory infection, but also damage that oviduct as well in that early stage. So again, like I said, it's a coronavirus. I have a picture of a Corona beer. I hope you can see that. It's not beer o'clock yet, but sometime soon. Again, this virus is moderately resistant, but it can be inactivated by some of the more common disinfectants like quat, bleach, all that stuff. The biggest antigen factor is the S1 spike protein on the surface, and that's where you can identify the different serotypes of the bronchitis virus. But the other part of it is this virus is very, very highly mutational, kind of like avian influenza, so it's really annoying. But here's a picture. This is an electron micrograph of what a coronavirus or the bronchitis virus looks like. You can see that you have these little spikes on the surface that gives it the kind of, corona means crown, so that's the crown that you're seeing on the virus. And the annoying part about the serotype thing is there's very little cross protection between those. So that's why you vaccinate for these different types, like Arkansas or Massachusetts or Connecticut, Delaware, all these different strains that you vaccinate for. That's why, because you don't have very much cross protection. And again, sometimes there are some subpopulations within these serotypes that might not be genetically identical to each other. So it's super annoying. And this is kind of my simple brain on if you have different spikes on the spike protein for the bronchitis, you're going to get different serotypes. So that's how it behaves in the bird. That's how we're going to see on these diagnostic tests. Again, it's super contagious, and it doesn't take very long to see the clinical signs if you have some. And most of the time, you might see some mild respiratory symptoms if you have younger pullets get affected with it. And it can remain fairly infectious for a long time, especially in the wintertime when the virus likes the cold temperature. So it can remain up to almost 2 months as an infectious virus particle. And feces is where most of it gets spread to. And the other part of it, so there's a double-edged sword, right? So the virus gets spread through the fecal transmission, but also it stays for a long time in the cecal tonsil. So this might be a good spot when you're looking to isolate the virus. So people have used fecal swabs. Also, they have submitted cecal tonsils to do some virus isolation. And again, it survives for a fairly long time as the virus itself. And because it's a fecal transmission, you can have all these mechanical vectors from equipment, from people tracking it in, contaminated litter, all that stuff can potentially be a source of bronchitis. These are some of the stats. I did not come up with this. These are summarized from literature that I deboed from Dr. Trample. Thank you, Dr. Trample. And so you can see that it can cause a lot of these issues. Some of the more notable ones, meaning being the albumin quality, it can drop a lot of that plumpness in the albumin, so it'll decrease the HA units a lot, as well as you're seeing these soft shell or wrinkly eggs that you can see on the surface as well too. If you have brown layers, then you might also see a loss of shell color and also some slab-sided eggs that you can see with it. The more common ones that I have seen, you'll see a different gradation in the color of brown. So you can see kind of like a dreamsicle color bronchitis egg. So here are some of the pictures you can see. You can show on the top parts, you can see some of these cracked eggs because they're thin. You can also see like an imprint on it, like they're stuck to the side, and also some wrinkly ones on the bottom right. Here's some more pictures of some wrinkly eggs, and these should all be brown eggs, but you can see that the color has faded. And then here's some more, I guess, current ones. This is from 3 years ago that I was investigating a flock that had some bronchitis issues. This one, we were never able to isolate the virus, but the titer, when we checked the blood test, it was like titer group 17 or something. It was some crazy high titers on this. But again, you see some eggshell abnormalities. And again, these are all supposed to be the same color brown, but obviously you see a different variation. And again, as far as diagnostics go, what I usually do is I might not be able to find the virus. So I try to do a paired acute and convalescent serology titer to look for it in ELISA. The other one that some people say it's useful, some people say it's not, is the HI. I've usually sent it to PDRC in Georgia, and they have some serotyping where they have 4 different types of the bronchitis strains, and they'll look for which one it's most reactive to. I've used it more for vaccine success as people are actually giving the vaccine properly. The other one is virus isolation. This one is a little bit tricky because you'll kind of chase it up with a PCR. If you have a live vaccine, the vaccine strains will test positive. But again, if you're looking for a novel kind, especially in like the oviducts for the non-layer syndrome, you might have to submit these oviducts to look for these viruses in the actual area that it's affected. And again, obviously, you might find some in the cecal tonsils if they're shedding in there. And then I'm going to hand it over to Dr. Algazar.
Hello, good morning, everybody. I'm Mohammed Algazar. I'm going to be talking briefly here on some of the molecular diagnostic options for infectious bronchitis. And I know that maybe not everybody is well versed in molecular diagnostics. So believe it or not, the molecular diagnostics and understanding of it can be easy. So that's what I'm going to try to do here today. So in addition to serology and virus isolation, molecular diagnostics is another heavily used option for infectious bronchitis. And when we talk about molecular diagnostics, PCR, it's not the only molecular technique, but it's one of the more common one that is used. And when it comes to PCR, there are 2 main types. So we use PCR for detection and PCR for classification. And the one that's used for detection is called real-time PCR. And the reason it's called real-time PCR is it actually monitors the amplification as it goes in real time. The other one is just classical gel-type PCR, where we target a specific segment of the nucleic acid of the virus or the bacteria, whatever disease we're working with, amplify it and look for a sequence. So because infectious bronchitis is an RNA virus, so we have 2 major types of nucleic acid, RNA and DNA. Because PCR can handle only DNA, we have to convert the RNA of infectious bronchitis into DNA first, and then we can do PCR. And because of that, the real-time PCR is called reverse transcriptase PCR. Reverse transcriptase means we convert RNA into DNA before we do amplification. So this is where the RRT PCR comes in. So real-time reverse transcriptase PCR. So we'll move on, and generally real-time PCR, whether it's reverse transcriptase or normal real-time PCR, targets small nucleic acid segments. So it's very small target of the nucleic acid of the virus or the bacteria. And the reason for that, we want that amplification process to be efficient, to be sensitive. The bigger the segment that we're targeting, the lower amplification efficiency we have, the lower sensitivity we have. So real-time PCR generally is very small segments. So the 2 real times commonly used with infectious bronchitis here is only around 140 base pairs. Base pairs is the unit that we use to measure the length of the target segment. So it's a small segment, and the outcome of real-time PCR usually is positive, negative. We want to know if the sample that we're testing is positive for the nucleic acid or is it negative. And because of that, we usually target universal segments, right? Segments that are not variable from one serotype to another. Segments that are stable, that are going to be present in all infectious bronchitis viruses, but can be present only in infectious bronchitis virus. So it's sensitive and it's specific. However, having said that, there are some serotype specific real-time PCR that have been developed. So in these cases, the real-time PCR can give you positive, negative, but also can tell you it's a Massachusetts site. So the table here on the right gives you multiple real-time PCR that can be used, and they are serotype specific. So there are a real-time PCR that can be positive only with Massachusetts, can be positive only with Connecticut, and so on. So, and we'll talk in a little bit on how do we use these serotype specific real-time PCRs. Now, the other kind of PCR is conventional PCR. And what we do here is we amplify a relatively bigger segment of DNA or RNA, usually in the vicinity between 700 to 1,000 base pairs. So remember, the first one was 150, small, it's efficient, it's sensitive. This one is bigger, and the reason we're doing a bigger segment is we want to extract sequence information from that segment and look at different sequences and compare them. And if we have between 90 and 95% sequence similarity, then we can say, yes, this infectious bronchitis serotype is similar to this, or it belongs to this serotype. This infectious bronchitis sample belongs to Connecticut serotype or Arkansas or any other different serotype. So 90 to 95% sequence similarity is the kind of agreed upon match that we would consider the sample to be belonging to the same serotype. So here's what we might be doing as a diagnostic plan for infectious bronchitis if we're gonna be relying heavily on molecular diagnostics. So universal real-time PCR just for detection, positive, negative. But keep in mind, as Dr. Sato just mentioned, that the vaccine will be positive on these real-time PCRs. So the negative result on a universal real-time PCR is gonna be more meaningful compared to a positive result. However, when we get a positive result, we're going to move to the second stage, which is amplifying a bigger segment and sequencing it and trying to identify or define the serotype of this virus. Is it the vaccine? Is it a different serotype that's from the field? Is it a challenge? And also, we're going to be utilizing other diagnostics information like serological evidence. So do these birds seroconvert? Do they have antibodies against that specific virus or not? So first step, universal real-time PCR. Second step, amplification and sequence and identifying what serotype that is. And that will be useful in determining what kind of vaccine we use, how we're going to move forward in controlling that specific serotype. Now, the serotype specific real-time PCRs, they can be then developed if we established an outbreak. Let's say here in Iowa, hopefully that's not the case, but we have an outbreak that we know going on from a Georgia 08 infectious bronchitis virus. It's in the population. We keep detecting that virus over and over and over again. So we can develop a real-time specific for Georgia 08. And once we have that, any positive result on that real-time PCR, it's not general anymore. We know for sure it's a Georgia 08 infectious bronchitis. So we don't have to go through the second step of sequencing and identifying the sequence type. So that's a kind of a general plan of how molecular diagnostics could be used for infectious bronchitis. And with that, I'm not gonna hold it any further. Here's what you are all waiting for, Dr. Bernie Beckman.
Good morning, everybody. Let's start with the first slide there, and non-layer syndrome. And to classify that just a little bit further, we want to go over is that it's an ovulating, so that means the ovary is in these birds are fully functional and they appear normal when we necropsy these birds. The non-layer part comes from is that you'll see in some pictures that we don't have a functional reproductive tract. Okay, and then syndrome is possibly because it's something new to the U.S., but as you've heard previously, bronchitis has been around for a long time, so it's an old disease, but it's presenting a new syndrome. So if you hear the terminology ONLS, you kind of have an idea of how that breaks down. For the U.S., I'm going to add Canada here once in a while, but for the U.S., it was first noticed in the spring of 2017, with the pullets actually placed in the fall of 2016. The layers never peaked. You're asking why, and a similar time frame in Canada, Ontario, and Quebec. Just to add to that is that they actually had 2 cases identified in 2015. And it kind of just disappeared after that for a while until it showed back up about the same time that it did in the US. History continued, no indications of any problems during lay, during grow. No significant findings on serology. And so here, when I say that, I'm probably looking mostly for Newcastle, AI, or bronchitis. Why do I have this graph up there? Is I want to point out how everything looks really normal in this flock. Mortality looks good. You've got feed, case weight, but the one part of that is just not peaking. That's one of the kind of the characteristics of this syndrome. And just another graph. Here again, another flock doing the same thing. I mean, you can see that everything should be going along really well with these birds. And for whatever reason, we're just hitting a peak, and they just level off at that level. So what do we have here in this picture? What I want to demonstrate on this picture is you can see that the yolks are there, fully functional ovary. And one of the things when you first open these birds is you might think, well, that might be peritonitis. But what you're seeing there in that liquid is as these yolks, the bird is cycling and ovulating normally, and those yolks are just dropping into the cavity and being reabsorbed. So what you find is a clear yolk-looking liquid. It may look a little watery but that's because it's being reabsorbed, being broken down and being reabsorbed. So that's kind of when you first cut into them, one of the characteristic signs. A little more after these are from live birds, starting with the reproductive tract on the far left. That's a full functional reproductive tract. You can see how long it is. The next one in the middle is from a bird with false layer. You can see that the tract isn't developed. And if you look down right above the April 26, you can actually see some small cysts, water-filled pockets. And then the one on the right there, on the left-hand picture, that's a reproductive tract. When it stretches out, it's missing segments. If you look right in the middle there, part of the reproductive tract just didn't develop. The picture on the right is showing a normal ovary and a reproductive tract that's only maybe a fifth of the length of what it should be. And so those are the characteristics that I guess I'm classifying as this false layer. The other one that you can have with this, and I'll show a few pictures with it, is these oviducts have big cysts on them as well. A little more history. In the U.S., confirmed cases in Arizona, Wisconsin, and Pennsylvania. Flocks in March and April 2017 were peaking at between 75 and 85%. The Canada flocks were worse, with flocks even as low as 50%. All strains, brown and white, basically just about every strain out there's had a flock. As of April of 2018, the total number of birds involved is around 2 million, and that's for the US. Canada, around 1 million. The number of new breaks have been significantly less this past year. The oldest birds now with lesions are 60 to 80 weeks of age. Going back up one step is that when I say significantly less the past year, is that the birds in Arizona and Wisconsin, they had their initial break with several flocks in a row and then hasn't had any since. Here again, just some more pictures reminding you of what we're talking about here. Fully functional reproductive tract on the left and some reproductive tracts, the next two on the right. An interesting finding has been 3 to 5 flocks break in an area. And here's an important point: with no changes, the next flocks peak with no issues. So there was no intervention at all because we didn't know the other flocks weren't going to peak. So those birds went back into, in some cases, the same growing houses, in other cases, but they all would have been with the same company. The PA situation may be a little different. The same pullet houses having repeat cases, and it's been a little more sporadic with the confirmations there. And we have a more recent one there within the last couple of months. In the layer flock, clinical signs: normal mortality, appear bright, eating, normal, bright combs, pelvic bone spread, active ovary. Yolks free in the abdomen, no oviduct from non-developing or oviduct with large cysts. So at this point, it's not like it's a regressing oviduct. That oviduct never developed to begin with. The other way that we can have this happen is that there's these large cysts that actually just produce so much water that they take over the reproductive tract. Externally, almost impossible to differentiate from healthy birds. The clinical signs when handling is a large fat pad or penguin stance, water belly type condition, plus or minus small ulcers on the combs. I apologize, I don't have a picture of those small ulcers, but that's just exactly what they look like, about half the size of a pencil lead. There's just small ulcers. It's not like a pox lesion where there's a scab. This is more just where it looks like the skin is off. No outward clinical signs of respiratory disease are seen in pullets or layers, as birds were theoretically affected in the first 3 weeks of age. Okay, another picture as you're trying to find these birds in a layer house. Normal looking breastbone, normal looking breast development, but an extremely distended abdomen. And when we cut into that, here again, it's showing by the hand a lot of fat in these birds because they're not producing any eggs, they're reabsorbing everything. And again, normal yolks in that bird. Here is the other condition I was talking about, where this is a cyst on that reproductive tract. Apologize that isn't laid out to show you the ovary. One thing I don't want this to be confused with is what we originally called years ago is called water belly. And that water belly was actually from the non-functional reproductive tract, the other side. And we'd have these big cysts in those, and we'd just kind of cut into them, call them water belly, and move on. This is a cyst off of the functional oviduct, and showing how big that can look. No issues from the birds producing eggs. No issues with the eggs. Serology, MG, MS, IB, Newcastle, no findings. I should have AI up there because they were checked for AI, nothing there. If the IB challenge is within the first 3 weeks, testing birds around 3 to 5 weeks for serology. The problem with that is we're vaccinating, you have declining maternal antibody levels, you have vaccinations. And is this virus does it even produce a significant serologic response? We don't know those things yet. And so do our tests actually produce detectable antibodies in that case? Lesions. So the oviduct is gone or underdeveloped, can have cysts. The ovary is normal with production and a normal cycling. The ova are released in the cavity. Free is in the free yolk in the cavity as in the pictures, becoming reabsorbed. Secondary, you would think that maybe secondary peritonitis would be a problem with this, but you got to remember the cavity itself is sterile, and just having the yolk in there doesn't necessarily mean that they're going to have peritonitis. But it hasn't shown to be a significant problem in these flocks at this point. Here again, just a picture showing you what we're talking about. ONLS is felt to be from an early exposure of bronchitis. In Canada, IB strain DMV 1639 has been isolated from several flocks and early on. In Europe, they have demonstrated the QX strain to create this lesion. With the QX strain, the lesion has been reproduced. The reason I make that statement there, reproduced, I do not know of any strains isolated in the US yet that that we've taken this and reproduced this from the strains that we're dealing with in the US. And also in Canada, they have not taken the DMV strain and actually reproduced this in chicks. In the US, DMV 1639 has been isolated. Is it a cause? In the Western state, a nephropathogenic strain with the potential to disrupt the reproductive development has been isolated. The reason I say that is the reproductive tract early on in these chicks actually developed. There's some common cells with the kidney that form the reproductive tract. So if it's getting in there early enough within that first couple of weeks, we could have, that by it being demonstrated as being a nephropathic or a kidney type strain, that maybe we're maybe onto something that actually is our isolate. Development of the reproductive tract from the kidney tissue in the Midwest state, that would be Wisconsin, that those isolations are ongoing, as well as Pennsylvania. Factors involved in subsequent not having an issue: change in season, more ventilation, C&D between flocks, biosecurity, isolation the first weeks. The flocks that I had worked with, the biosecurity thing we were trying to work on anyways, and I don't know if there was a correlation there that for whatever reason that helped, or if it was the C&D between flocks. But here again, remember I'd said there was absolutely no changes we identified when we went from flocks having the issue to absolutely no issue. Treatment. There is no treatment for a bird with a condition. Identifying and culling was actually tried, but that's as you guys know, when you go into these big flocks, that can be very difficult. Birds severely affected will not recover. They will never start. They won't recover from this lesion. Prevention. we need to find the types of IB causing the lesion, cyst, and non-functioning reproductive tract. I actually have it up there as being two different types, and maybe we have an IB that causes more cysts and one that causes just that reproductive tract not even to form. Prove these viruses isolated are the cause, and then challenge studies with known vaccine to prevent or the production of a new vaccine. Risk reduction practices, biosecurity the first 4 weeks and grow. The use of a commercial monovalent vaccine with broad cross protection. Vaccination day 1 and 14 with IB. No NCD in the first 2 vaccinations. The reason we don't want to put the Newcastle in there is that it seems like for our Leghorns, if we put Newcastle there day 1 and 14, that is really hard on the birds and we get really too much reaction. So if we can stick with just a bronchitis, there's several types that can be used out there, Georgia 08, MA5, anything that's just, Arkansas is not one that's been recommended in this so far. And that is from one of the researchers that work with IB all the time. So that's kind of where we're at there. We will need to know the challenge strain and type of maternal antibodies are produced if an autogenous is given to parent stock. A lot of talk about, producing maternal antibodies in the parent stock to protect these birds the first couple of weeks. But we first need to find out what our challenge strains are to be able to even put those back into the parent stock. So that we have the right maternal antibodies, because as the earlier talks were, these IBs sometimes can be very finicky in that they only want to, if you don't have exactly the vaccine to match up with the challenge virus, the vaccine won't cover it. Challenge past 4 weeks with the QX strain. Remember, this was the one from Europe. Little damage to the reproductive tract, and that is completed research. So you're saying, why just the first 4 weeks? Is that it appears these birds can handle a challenge strain after the 4 weeks and not be affected as far as the reproductive tract. The age of infection has a large impact on the amount of damage. Damage is strain dependent. And here's the other one, did the virus change or an introduction? And here again, from earlier presentations, we know that these viruses can change, and it may not, we may be still dealing with even a mass or whatever, but did it change just enough that if it's that virus that's on your farm changed just enough to cause this lesion now? The other thing I want to bring up is that all farms have bronchitis on there all the time. It's not like we're operating farms without bronchitis. There are resident strains on your farm, just like there is Merrick's in the dust and dander. Bronchitis is there all the time as well. The phylogenetic tree shows the PA98 closest relative to the DMV 1639. Both of these strains have been problematic as control with available vaccines. There are no commercial vaccines for either strain. So if these are our problem strains identified, then we will still need to be working on, number one, demonstrate they create the problem, and then two, we need to get a vaccine made out of them. Summary. If and when the cause is clearly identified, the use of live or kill vaccines, and to produce high levels of immunity in the chicks, preventing early challenge is still important. Should everyone be using an IB vaccine, day of age, in 14 days? Farms with a history of this problem, yes, you got to be doing something. Even with what I said that we don't have a lot of answers to this, we probably need to be trying to give it our best guess. And So with those, I would say yes. Farms with no history, in my opinion, this is still a big shot in the dark if current vaccines are even effective. We have no demonstration of that to this point. And the reason I say that is the farms where we have started day old and 14 days, there were several flocks in there that received nothing from and did just fine. So we don't know what we're doing in the field right now is effective or not, but if you have it on your farm. One other thought is, can you find this in a flock that's peaking at 95%? I have found this lesion right here with a non-functional reproductive tract. So I think the reason for bringing this up is I think you can have an individual bird problem with this, or you can actually have a flock problem. So I'd probably not get too excited with the individual bird problem, because this has probably been going on for years and we just never went searching for it quite to the extent that we are now. But if you have a flock peaking, let's say under 90%, maybe that's the classification for a flock problem. So with that, I think that's the end of.
All right, well, thank you. We do want to open it up and take some questions. So we'll need to just give us a second to unmute everybody. So everyone should be unmuted now, and so we'll take any questions if anybody has any questions for any of the three presenters.
Hey guys, this is Rosie from Daybreak Foods.
Okay, so just a second, Rosemary or Katie, I'm not sure who that is. I heard Daybreak Foods, but I wanted to ask if you are, now since everybody is unmuted, we're picking up background noise. So either you need to mute your computer if not asking a question, or you need to kind of watch that background noise. Okay, so I believe someone from Daybreak had a question.
Yep, thanks, Kevin. This is Rosemary. I guess this could go to either the pathologist or to Bernie. Do you recommend that perhaps we, for our pullet flocks, save the Zika, freeze the Zika for the first 4 weeks, just in case? Or what do you think about that?
So this is Bernie, and it's been very difficult to isolate this. And if you suspect that there, Rosemary, that you might have a problem, I think that would be a great idea. The other thing maybe would even be taking tracheal swabs and freezing those back at the same time. They've had some success with that in other locations in Canada, actually taking tracheal swabs. But I agree with you. The Zika are definitely a source for them as well.
Okay, great. Thanks.
Yep, everybody else in the room is shaking their head in agreement. So I'll take any other questions. TJ, did you have a question? I thought we saw you maybe start to ask a question. Just wanted to make sure we give you that option if you want to. Okay. All right. Well, hearing no other questions, I want to alert you to our next webinar, which is scheduled for June 1st, also at 11 a.m. And it'll be a report on some of the latest happenings from egg marketing and promotion standpoint. We'll be just coming out of May Egg Month, and we'll be sharing some of the updates on the marketing efforts taking place both at the national level, but also within the state of Iowa. So we look forward to having everyone join us on June 1st. Otherwise, everyone have a great May Egg Month, and we'll talk to everyone soon. Thank you.